group here with us today. I'd like to take a few moments to introduce them to you. Let's start on the far right over here with Hank Fanberg. Hank is our Director for Technology Advocacy at Christus Health. Christus is one of the nation's largest Catholic healthcare systems with over 375 medical facilities and services across 8 U.S. states and over 9,000 physicians throughout the system. Hank leads strategy for health information technology at Christus, and he's also Executive Director for the Health Information Network of South Texas. He is Associate Project Coordinator for the Texas FCC Rural Health Pilot Program and also adjunct faculty at Texas A&M. So let's welcome Hank. Next, we have Artie Paniagua. He is Director of our Clinical Policy and Support for Centene Corporation. Centene is a healthcare enterprise that's Fortune 500 and supports providing healthcare services to the underinsured and uninsured, particularly when we think about Medicaid. And as many of you are well aware, when we talk about mobile technologies and innovations, there's a lot here about the Medicaid population that we would want to address. Artie has over 15 years of experience as a nurse. He's worked in various roles in healthcare, including the operating room, medical floor for nursing and performance process improvement. He's trained in Lean Six Sigma, and he currently serves as Director of Clinical Policy, as I said before, for Centene. So let's welcome him. Next up, we have Scott Schell. He is EVP and Chief Clinical Officer for Alere Health. And Alere is a leading, if not the leading, wellness care management, case management, women and children's health solutions provider. Scott's role encompasses clinical affairs, compliance, quality, integrity, analytics and reporting, and operations. He has also launched 3 companies in the HIT and EMR space and has extensive experience in consulting with pharmaceutical, biotech, and medical device companies. So welcome. And last but definitely not least, we have with us John Kansky, who is VP of Strategy and Planning for Indiana Health Information Exchange, or IHI for short. IHI is our nation's largest health information exchange organization, covers 90 hospitals, 25,000 physicians, 10 million patients. John has more than 25 years of experience in the health technology field. He served as the chair of the MHIMSS, or rather the HIMSS HIE Steering Committee, and is also a co-inventor on 3 U.S. patents for diagnostic imaging technology. Welcome. So the first question, of course, when we talk about innovative partnerships, I'd like for our panelists to just share with us, what are your experiences of innovative partnerships? So perhaps, John, we could start with you and what you're doing at IHI.
Sure, thanks, Al. So we're the nation's largest health information exchange. And I like to say, I just bragged about that. Now I'm going to tell you that we did that by cheating. We started 15 years before anybody else through a key partnership with the Regenstrief Institute. If you've heard of Regenstrief, it's a independent research institute internationally known for healthcare informatics and healthcare process research. Fast forward to the point that we're a growing health information exchange. We have certain challenges of scaling and have found, again, an innovative partnership with AT&T to be able to scale our services by partnering around implementation and being able to grow with reckless abandon, which we could not do before.
What about Scott? Could you share with us on Alere's innovative solutions and what you're rolling out?
Sure. We've really been involved with a wide variety of partnerships for the past actually 2 decades if you look at it over a longer time, with payers and hospitals and providers and also parts of the public sector. We have recently partnered with AT&T on the Diabetes Manager platform as an adjunct to enhance our existing constellation of biometric and mobile health devices. And really, these sort of partnerships are each integrating towards a more seamless and I think more effective, from a clinical outcomes perspective, ability to bring patients closer to their own health care and then engage them in a way that lets them change it for the better.
Artie, could you share with us your thoughts?
Sure, thank you. So Centene manages over about 14 health plans across the country, and we partnered with AT&T and our health plan in Ohio, Buckeye Community Health Plan, to roll out the Diabetes Manager application offered to about 200 high-risk diabetics there. And we're able to get some very, very good results, showing an overall decrease in hospital and ER utilization, as well as a decrease in hemoglobin A1C levels. So just shows the partnership again with Buckeye and AT&T, using mobile health, providing mobile health application devices to a population that, for the most part, hadn't had that ability to use a mobile device before. So we're pleased with the results for that pilot.
And then finally, Hank.
So Christus is a large health system. We operate in 7 states, 3 countries, people with multiple languages. And the point of all that is, when you have a large organization like a Christus or another large health system, those on the vendor side need to understand about 85% of our budget is going to keeping the ship going at its current path. And the amount of resources and revenue we have for innovation, while we talk about it and we want it and we need it, it's a very small component. So, number one, it could be difficult to get our attention, simply because we're just too busy steering the ship in the direction that it needs to go in. So we need organizations, vendors, from my perspective, that are willing to listen to us, that understand the breadth of what it is that we do, that are flexible, and are willing to work with us and not just come with a single package solution that says, here it is, this is the greatest thing, this is going to keep everyone out of the hospital, this is going to cure diabetes forever, all illness and world peace and happiness is now here. That's not going to work. That's not the approach. So we really need for y'all to listen and understand what our needs are and figure out how to fit in to the foundation that we have and help us get to where we need to go, because frankly the other thing that we need, and y'all have probably heard this from other sessions and from CMS when we talk about reimbursement, how do we get reimbursed for mHealth? Well, where's the evidence? Where's the evidence? We have a CFO who's saying, show me this is going to work. So we need to develop the evidence also. So that's why it's important to have partners that listen, that are willing to work with us, that understand the road may be bumpy from time to time. And when we find those partners, they really do become partners, and it's not just simply a vendor, a provider type of relationship. And those are some of the key things that we do look for. And I'll do the AT&T plug later on, though, but we are partnering with AT&T on a number of things.
And of course, it's not just, not just partnering with AT&T, but we're talking, to your point here, all the different partnerships that you have in place. So it's interesting hearing from our panelists here, their partnerships on the provider side, on the payer side, on the vendor side, whether it's infrastructure, devices, applications, connectivity, and it's getting darker here, but anyway, Hank, it was
Thank
a
God,
great...
I thought it was me.
So Hank, you raise a really good point, a great segue into, what makes a successful partnership. We've heard from you need for flexibility, to partner with you on joint ROI and evidence. And I'd like to extend the conversation to, to the rest of our panelists too. Maybe Scott, from an Alere perspective, what makes a successful partnership? What makes an unsuccessful partnership? Could you share some thoughts here with us?
So you'd like me to spend the next hour talking about unsuccessful partnership outcomes?
Let's start there, yeah.
Really, obviously, the first step to a successful partnership is that each party or each of the parties involved is going to bring a key that adds together to the greater solution. Whether that's care management and home care delivery, whether it's a device and a data system, or whether it's a mobile device and a care management platform. I think the thing that I've seen most clearly as effective and supporting these kinds of efforts really is when you have complete subject matter dominance in an area, and you bring two parties together in order to achieve that. And I think that synergy and a willingness to sort of to see beyond the two parts and a greater sum than the whole really is what makes it effective. Lawyers and politics and geographies and time zones all sort of interfere with those things, but I think that the key issue is a common goal and subject matter expertise and a willingness to play well together in the sandbox.
Yeah, so John,
If I could add, how many in the audience are kind of sort of aware of what health information exchange is? Okay, good. And now, put your hand back up if you feel that you're in a market where you live that has a basic, robust health information exchange that's functioning. Okay, that's literally, except for the panel, nobody. So, in order to succeed in health information exchange, you have to create partnerships between people that spend most of their time trying to figure out how to kill each other. So you have competing hospitals, not literally, you have competing health systems that have to come to the table to share data, which might initially sound like craziness to them. You have payer and providers who really have a generally hostile relationship that have to come together and cooperate to do something that either raises all boats, creates value, or that has a what's in it for them on both sides of the equation. So to be successful in health information exchange, and the lack of hands in the room shows how difficult it can be to create those partnerships among organizations that are currently in the reimbursement in the healthcare system incented not to partner. Happy to report that some of the payment reforms, things like ACOs, are driving new partnerships in healthcare that previously would probably not have formed.
Yeah, to that topic of partner or organization to organization partnerships, Artie, I know you've got a great case example here of your partnership with Buckeye.
Right. So bringing it back down to the pilot that we had partnered with Buckeye on, we really relied heavily on their local knowledge and their local local knowledge in terms of their membership and local expertise and how to more effectively reach out to those members. They knew their membership, they knew their what worked in the past, what didn't work in terms of going out and outreaching and being able to roll out this project, and I think that was very instrumental in making this a successful pilot with them. So.
Yep. Now, we have obviously two parts to this discussion today. One is on the partnership part, and the other part is on the innovation part. So, we've heard it time and again, so many different suppliers out there. The market is awash in vendor solutions. How are we thinking about the supplier space? Are you seeing true innovation? Are you seeing more of a repeat of Me Too's? And what are you looking for as, leading healthcare enterprises in rolling out more innovative solutions in this space? Hank, would you like to weigh in here?
Yeah, pick on the providers. Well, so at some point in time, so take an example, you go down to the exhibit hall here, and there are a lot of really great applications that are out there. And after a while, they do kind of sort of look alike, and you really need to get underneath it and really understand, what platform are they on, what can they interface with, what can they do, how can I use them in my environment. We have electronic health record that all the doctors use, the same one. So are we going to have difficulty in interfacing that? We want the data, we want the doctors to have seamless access to the data regardless of where it may be coming from. So when we take a look at innovation, we have to take into account how we're currently acquiring data. I'll use the workflow term, or process flow. What's happening? Is this going to fit into what we do? It's not just simply the latest and greatest app that's going to make a change and make things more convenient. It has to fit into the foundation that we already have. That being said, we are in desperate need and dire need of the innovation to help us change the way that we used to do things. I think John gave a great example. With the HIEs, we're trying to change how a medical community interacts together, and there are probably applications out there that'll help us do that, but I maybe haven't looked hard enough or haven't quite seen it yet. So those are some of what we need to do. How we're delivering care is changing. There's no doubt about that. No one's going to argue about that. There may still be issues around how the providers get reimbursed, but we need to open up the communication channels and have more communication. So innovation is critical, but again, getting back to my earlier comments about our needs and fitting into the foundation that we have, the innovators have to have some understanding of where we're coming from, and not just, here, we just wrote this great app, and go ahead and use it, and things will be fine.
Yeah. John, when we talk about innovation in workflow, per what Hank was saying, what have you seen in terms of the innovations in that workflow piece? And
what I was thinking about when Hank was talking is, and I don't think health information exchange is unique in this regard, is that if a vendor has an innovative solution that they bring you, that's great. Mm-hmm. I don't think it's we certainly don't look to, we're not expecting those innovations to be brought to us and lay it at our feet. I guess what I'm trying to say is that, especially looking through a mobile health, thinking about mobile health innovations, so many of those innovations are enabling, and it's incumbent on us as health information exchange providers or healthcare providers to recognize that, wait a minute, something just changed in the marketplace because of this enabling technology. I can't expect that vendor to recognize that they just solved my problem all the time. I have to piece 3 technologies together that didn't exist before to solve a problem that's probably existed in healthcare for all time. One example that I can think of that I heard about recently is, so we have a challenge sometimes of there will be bedside healthcare devices that are not integrated to the electronic medical record. So we've got manual data entry that has to occur from reading a piece of data off that device and getting it into the EMR. Or you can do all kinds of crazy integration. It's not crazy, but it is hard. I heard about an innovation recently where someone takes part of the tablet that they're using to access their EMR, and they take a picture of the front of the device. It recognizes what kind of a device is, therefore knows where the values are on that screen and OCRs them into the EMR. That innovation took a few different, a recognition of a problem and the fact that a solution could exist that didn't exist before.
Barty, please.
Well, I was just going to add, when it comes to innovation, and still I'm thinking about the project that we did, I think we have to put the user, the patient or the member first. and focus not just on the what, but also on the how. Because again, with our membership that we were targeting, many of them may not have had a cell phone, or maybe a cell phone like we were using in the pilot, and so needed to not only teach about how to use the application itself, but how to navigate to get to the application to use it. And so I think we have to always consistently think about, okay, you can have a very elegant and very innovative solution, but if the user's not able to access it, it's kind of for naught. So.
Yeah, I agree. We often talk about in the industry about innovation, and our minds are drawn to the coolest, latest app or the greatest little gimmicky device. Maybe I shouldn't use the word gimmicky, but there is this innovation in how you engage with the patient. Scott, I know that Alir has done a lot in terms of thinking about innovative ways in engaging the patient population for better outcomes. Can you share with us some of the innovations that you've seen in this space when it comes to engaging the member?
Sure. We're in an interesting situation because we create some of these technologies ourselves and we partner beyond it. I'm thinking about John's conundrum about getting data off of legacy devices. One of our business units has a device the size of a stick of gum that will basically speak to every legacy piece of equipment, so you don't have to go through the mechanics of taking a picture and image recognizing. Patient engagement really has to do first with educating and empowering them about their own health diagnoses and their health situation. And disease management, it's easier because it really is about understanding the disease and then bending the curve. Case management is much more challenging because these patients have either internal or external barriers to achieving their health goals with or without their ability to understand the disease. And so we've found systematically a variety of platforms by which we've been able to engage patients. We have about 65,000 mobile health devices, biometric devices that are in patients' homes and workplaces that are gathering data every day. And so they no longer have to think about what it means. They can get on their scale or measure their blood pressure or their peak flows or their blood glucose. That information integrates into our care management platforms and allows them to have a much more contemporaneous interaction with our teams as opposed to multiple phone calls, manual data gathering, and some of what we've just heard. Certainly the ability to now have small computers in your hands that are ubiquitous and are used for everything makes that a lot easier because now the patients don't have to think of their health care as an independent activity. But I think one of the things that we have seen most compelling is that of the tens of thousands of mobile apps, and we're talking about in part some of our diabetes experience, there's over 300 diabetes applications, but there's only 2 of them that integrate seamlessly into a holistic patient care record that involves the patient's nurses and the ancillary clinical team members, but also links in the physicians through provider portals and the patients through their own PHRs. And I think that's a differentiator because the key is it's great to have the data, but then what happens with it? When you bring the data into an expert system with a linear data storage model and bright clinicians who can help act upon that, whether that's via a telephone call or a text message or an icon showing up on a smartphone. That's where the engagement in the chains happens.
Yeah. So I'd like to open the session up to questions from anyone in the audience, and as you think through the questions that you'd like to ask our panelists here, I'll also like to ask another follow-on question while we're waiting for folks to come to the mic, if at all. All of you have experienced innovation and the kind of partnerships that you feel you need to move forward with innovative solutions. Now, this is the question that's on everyone's, top of mind then, as very important healthcare enterprises that represent payers and providers, and the underlying, technology providers. In this case, with iHigh, are you now at the point where you say, look, we're no longer at the point of experimentation and piloting. We're now willing to go full scale? And I see Scott nodding, so I'll ask you first.
Again, the idea of distributed data and biometrics and mobile health is something that we've really been actively engaged with over 15 years. Our original solutions involved a rather boring box with an LCD display that hooked into wireline telephone services. And we have several thousand of those devices still deployed today. I think we've moved well past piloting for our core distributed or mobile health solutions. Really what is available moving forward from a pilot perspective relates to new technologies and new solutions. And to both John and Hank's point, it's very important that we look at these as disruptive change instruments. So you deploy them in a pilot setting, create credible evidence that demonstrates that it's having a desired effect. Stand back and think about it from a larger business perspective to ensure that although you're moving the needle, that it's actually a tangible and relevant investment to make for the available dollars that you can apply and then move it forward. Really, those are the pilots that we have in our enterprise.
Okay. Hank?
So the short answer is yes, but it's wrapped up in this conundrum because with a health system that's hospital-based like we are, part of what we're trying to do is figure out how do you really disrupt the way that you've provided care and that you've generated revenue historically, because doing it in the future is going to be very different than it is or it has been historically. Right? Reimbursement is changing. We have ACOs. We have patient-centered care. So there are two sides of the coin in terms of it's gone beyond just, do we need innovation, do we not need innovation, recognizing we need to do things differently. So on the one hand, if you take a look at from the big picture, and the big picture, the big data word, large health system, we take care of a lot of people. We have all this information. How do we make sense of it? How do we take outpatient information, inpatient information, patient-generated information, and get that into the hands of the clinicians and let them decide what they need to do to make better clinical decisions, improve the quality of care? So we have data aggregation needs and sifting through the data and being able to learn from the data, and then we have the actual provision of care. And how we do that needs to change also. And I think both Artie and John were talking about the patient. We need to understand patient preference. We need to understand how best to communicate with the patient. Not everyone has a computer at home. And frankly, one of the things that we did find within our populations, and we have a lot of different patient populations, Texas leads the country in the number of uninsureds. So regardless of someone's economic status, there's a 99% chance they will have some type of cell phone. It may not be the latest smartphone. It may not be an iPhone. It may be a flip phone. It may be a prepaid phone. But we know they're going to have a cell phone. So how do we leverage a cell phone to enable us to provide better care? And if they don't have any of those, we've gone to the situation now to try to prevent readmissions, which is a big initiative, CMS, quality initiative, where we are actually taking tablets and sending them home with the patient so we can communicate with them, because your octogenarian who has just been discharged from the hospital, who's in heart failure, may not know how to use a tablet, may have a basic cell phone they know how to use. So we need to make sure that they know how to use the tools also. So we're trying to get to that point of how do we enable the innovation, and how do we make sure that it meets the needs of an individual patient, and make sure that we can enable better care by understanding what an individual preference may be or an individual need might be.
So if I could distill, it sounds like, that we are truly at this tipping point, but what is needed is more clarity on the specific solutions, return on investment for you as healthcare enterprises, being able to understand better the implications on revenue generation and reimbursement, ensuring that the solutions have, that ability to integrate both into your data, your workflow, and how you interact with the patients. So I guess the question here then, following on, is, we saw with the federal mandate how EMR adoption, HIE adoption is increasing, and I know, John, you could speak a lot to that point, but John, I'd love to hear your thoughts too, are we saying for these other innovations, what really needs to give this a good kick in the pants is some kind of federal incentive?
My favorite comment on the federal incentive is that we were trying to compel participation in health information exchange, which includes pairing your EMR and other information systems that you use with a health information exchange that allows you to connect with partners across the supply chain. We were trying to compel participation through return on investment and value before there was any federal incentive. The federal incentive has clearly accelerated that process, but I think that once meaningful use runs its course, we're going to be back to, frankly, where I'm more comfortable, which is you should do this because it has value for your organization or your patients.
Yeah. And I think we have a question from the floor.
Yeah, I have a question. Part of partnering is finding the right partner. So we can take some lessons away from the managed care experience 20 years ago. Early adopters were in California, and if you talk to doctors then, whether or not they made the best decision to jump in then, it's probably not the case, as what we learned from other folks' experience. Jeffrey Moore talks about crossing the chasm as a way of adoption of technology, and he has these early adopters that love to play with this technology, but real opportunity takes place when you get to the mature market, when you scale. So I wanted to get a sense from the panel of how do you identify the characteristics of an entity when they're moving from let's try a lot of little things and see what works, or let's just have a lot of discussion. And when you see an opportunity for scale, when people really benefit from it, when health systems benefit, from providers benefit, and what are the characteristics that you look for in either identifying the right partnerships, or when do you see this kind of scale happen that really makes a difference, and where are the impediments to making that happen?
Anyone of our panelists looking to...
And since Hank is smiling, I know he has a good answer.
He's holding himself back.
I wanted to hear from the other side of the street first, actually. But
Actually, could you identify yourself to us?
Oh, yes,
also,
my
you know who's
apologies.
asking?
Sure. I'm Daniel Gold, and I'm...
No, he was getting ready to talk.
although Lear happened to be one of our customers, so I know a little bit about Lear.
Well, from a health system perspective, we're not necessarily the highest risk takers that are out there, and we don't tend to be bleeding edge, although we have a small little innovation group that will take a look at some bleeding edge things. And frankly, I think it's one of the values that an organization like AT&T brings to us, where they're out there really doing a lot of the legwork and uncovering these smaller, newer companies that are trying really innovative things. So it's sort of like we don't have the bandwidth to really focus on that as much as we might. So having an organization that's doing some of the vetting for us that we can trust. Christus has a long history with AT&T. They're our backbone. We have our entire 40 hospitals across 7 states. We use AT&T as our backbone. So it's our core communication network, and what they've done in the health space and the mHealth space has been very beneficial for us. So we don't have to be the ones that are out there trying to overturn every little rock and see what the latest and greatest thing is. So we know that someone is out there doing that work for us, vetting some of the ones that are out there. So we rely on organizations like AT&T to help us understand who's out there, who's real, because and as we all know, the best idea doesn't always win in the long run. Look at Betamax. I still have a car that has an 8-track tape in it, but I can't get music for it anymore. Convert it into an MP3 player. So that's one of our approaches.
So Lear's role in the technology space has really given us a lot of opportunity to examine these questions as part of our routine business. And we have an organized new business evaluation unit. I like to think about it in the concept of try, die, fly, and buy, so that we look in the marketplace to see what differentiates. And so if there's 300 diabetes applications, are there one or two of them that have differentiators? Proven clinical outcomes, independent studies that show that if it affects markers of disease that are identified with long-term improved outcomes. And once we have that information in hand, then it's part of the try, a small pilot, internal, large enough to be sufficiently robust to show at least non-inferiority, but presumably better superiority. And if it dies, well, then it goes back into the pool with the other 300 that aren't differentiated. And then if it flies, then we can consider it as a partnership opportunity or an acquisition opportunity. And I think that may be oversimplification, but even with, was it 15 or 16,000 mobile health apps presently available in the public sphere, it doesn't take an IQ of 150 to go through them and identify that 90% of them are really not very interesting or not very innovative. Different colors, different themes. Very few of them have proven track records with clinical indices that are independently recognized as being important, and which, if we are able to improve them, we'll know that the diabetic will do better or stay well longer.
Now, I'd like to also hear from you, John, as well. You know, IHI, you've got 10 million patients, 25,000 physicians. If anybody can talk about scale here, what is, you know, from Dan's question early on, what is compelling you to be able to obviously go away from the testing to the, you know, the flying stage, as Scott was saying?
In terms of the scale of our health information exchange, or the sustainability, it's best to ask that question in terms of a service. So our innovation comes when we have a solution to a new problem that a health information exchange hasn't addressed before. I don't know if I'm explaining this well, but health information exchanges should deliver lab and radiology results electronically. Duh. Okay. But going on to progressively more sophisticated solutions, where do those ideas come from, and when do you know you can scale them? One of my responsibilities at IHIE is to try and identify those new services that are both possible and would have value in the marketplace. And they come in two directions. One is, I think I have a great idea, or somebody that works for our company thinks we have a great idea. Those are usually not the good ones. The good ones are the ones that come from your customer base or your partners, and they bring you a problem and they say, this is killing us. And you say, well, why don't we just do this and this and this? Because you needed those partners and some innovative thinking to come together. The scaling of that, I think, things fly on their own. There's times that we feel that we've got those ideas that we're pushing the bird out of the nest and seeing if it flies, and that happens sometimes, and sometimes they fly and sometimes they don't. But there's also times that you hear about customers have found a way to use your service in a way that you weren't even aware of, and those things take off because they solve a real problem. Sadly, you didn't even realize it. It wasn't your great idea.
Kind of like an off-label use for your solution?
Yes, yeah. Absolutely. I can give a quick example of one. So, like I said, all health information exchanges should deliver lab and radiology results. Duh. And we put those in either the physician's EMR, or we put them in a web-based portal. Well, we found that there were typically nurses working in physician practices, that the results would come in so fast to them that there would be patients that they would see. They would say, now you should take, or they'd take a call from someone say, you really need to take Johnny to the emergency department, or they'd see a patient that they knew they'd sent for follow-up. And they will start using the notifications that they know they would see. There will be a lab result that would result from that referral, or there will be a transcribed report that would result from that referral. And they were getting those results so reliably that if they didn't see the result, they would call and follow up with the patient. Now, we talked about you taking your son to the emergency department, and I know that you didn't do that. How did you know? And it was just because of the way that they were finding to use a very reliable, time-predictable method for receiving results.
Mm-hmm. Now, when you were thinking about rolling innovative solutions out at scale, part of that is obviously bringing the clinician along for the ride, but part of it is also bringing the end user. And especially when we're talking about whether it's a mobility application or connected device, what we've seen in the marketplace is typically after the 10th use of any kind of mobile application, not in healthcare, just any kind of mobile application, any kind of industry, after the 10th use, you're pretty much done. So, Artie, you have had experience here. When we're thinking about, again, using John's point about, getting to the fly stage, how are you thinking about getting the patients to continue to engage in these solutions that, you're investing time and effort on?
Well, I think for the project that we completed with AT&T, our engagement was very high. We monitor them on a weekly, sometimes daily basis, depending on how high risk they were. But we required them to make entries daily, at least one entry daily, blood glucose, carbohydrates, medications, those kind of things. And over the life of the pilot, which was 6 months, we saw engagement around at least once a day for the majority of the patients. So I don't think engagement was an issue for us. The biggest challenge we faced was, again, was rolling it out to them, reaching out to them in the first place, connecting with them, getting the training done. Mm-hmm. Certain technology limitations. Some of these areas where these members were living were very rural areas, so not a lot of cell phone service coverage areas out there. But we had other challenges in terms of that. But I think as far as engagement goes, they were very engaged and very interested in their health. So they craved feedback from our pilot participants. So I think that's not a big issue for them.
Yep. And I think that's interesting too to see in healthcare, because you've got the Pew Research numbers saying 9 to 10% of individuals are actually downloading and using mobility applications. But if you get that right application or the right solution, as John was saying, across the 300 and finding the one that works. And then, being able to deliver it to the end user, because when we think about, the cacophony of solutions out there, how do I as an end user, particularly if I'm a Medicaid patient, getting access to that solution? And it sounds like when you do get that, you do see that scaling and the rolling out.
Yes.
Yeah. Any other questions from the floor, from our audience here? Please.
Good morning. Scott Cassidy. I'm with West Health out of La Jolla. And this is my first mHealth meeting, so it's very educational. Thank you for the panel on the topic. Innovation and this partnership discussion, I'm a little curious if the panel can speak to innovative business modeling, business transactions, revenue differences, how you make money that you've tested, and the way each business is actually also having to challenge some assumptions about their own planning into the future.
Well, it has absolutely nothing to do with mHealth, at least not directly, but health information, some of the greatest innovation in health information exchange is around business models and trying to figure out how to make money. I was challenged by one of my co-panelists this morning on, so how are you guys sustainable? I won't point any fingers, Hank. But you have to be. So if you're a health information exchange, I like to say, if we were a dry cleaner, everybody knows that business model. You take dirty clothes, I charge a fee. I pay you money, give me clean clothes. Health information exchanges, there are no tried and true business models. You got states that have become health information exchanges. You've got health information exchanges that are not for profit. You got health information exchanges that are for profit. You have those that charge the physicians. You have those that don't charge the physicians as a matter of religion almost. And so there's I think tremendous innovation there. It's one of my favorite topics. I love lecturing my co-health information exchange people who, there's a number of folks in the health information exchange business, less every day, that don't understand that the marketplace is somewhat merciless, and you either do something that creates value in a reasonably easy to understand way for your customers, or it doesn't matter how much benefit you have to society. You have to do something that people can buy and understand the business model. One quick example is that we have leveraging a giant pile of clinical data. There's a number of things that you can do. One of the things that we do is we have a clinical quality measurement program. Who pays for that? In this case, we went to the payers and said, you're going to do a clinical quality measurement program for primary care. Let me explain why we can do it better than you can do it yourself, because we have aggregated data, we can have a multi-payer program, yada, yada, yada. So there was value to them. So we sold them that as a service, and it enabled us to provide actionable patient-level data to physicians at no charge to do something that health information exchanges as part of their mission are supposed to do, but it's a sustainable business model. I think there's interesting innovation there.
So Alere isn't an exchange or a plan or an aggregation of hospitals. We're a for-profit corporation. We look at our business interactions from the standpoint of evidence-based outcomes. Last time I looked, I think we have 16 or 17 million patients that we manage on a day-to-day basis, and several petabytes of active data that are going through our data systems. So we can look very systematically through our book of business across all of the service lines and activities that we engage, and because we have a large wealth of data, we can go to La Jolla and say, gosh, we know you're part of the world, and we can look at your performance, and I think very accurately look at it from the standpoint of modeling an outcome. And then the arrangement is pretty formulaic. We'll deliver better value than you're spending, and that's how we solve the problem from the standpoint of business returns. There's a lot of innovation. We have a team of predictive modelers, and we look very carefully at the data, and we draw conclusions not only within a region but more nationally, and can get some useful discernment by looking at the outcomes in ways that may not be apparent. And I'll give you one object example. We can get much greater engagement around wellness participation and employees performing and actually following through their wellness challenges that decrease their weight, increase their exercise, change their eating habits, lower their cholesterol in certain business sectors by spending $100 than we can by spending $800 in another business sector. And I'll let your minds sort of entertain you as to what those business sectors would be. Let's just say it doesn't matter how much you give an auto worker in Detroit.
Hank or Artie?
I'll just add real quickly, for us, it's for an innovative solution, it's less about what we can make off of it as opposed to what can we prevent in terms of dollars, for this project, for example, being able to keep them out of the hospital, keep them out of the emergency room, being able to show that compared to a control group or do some propensity scoring, those kinds of things, and evaluating a solution. But so I think it's more about how can we, and to Scott's point, to promote health, but also prevent those dollars in terms of hospital admissions and ED visits, for example.
So the hospitals, we're the victims of the other ones at the table here. And this is really one of my favorite soapboxes, so thank you for the opportunity. I presume some of you in the audience are what I kind of call, the vendor community. You have a company, you have a product to sell, some technology. Am I correct? Some of you, not everyone's a provider, right? Okay, so the hospital industry, the gross profit margin of the hospital industry is between 4 and 8%. Those of you that have companies, can you run your company on a gross profit margin of 4 to 8%? Mm-hmm. I would venture the answer to that is no. In order to grow, just our normal reinvestment back into the business, to do tomorrow what we do today, takes at least 4% return. And if we don't have that other 4%, we don't have any money to do anything else. So my message to you all in the vendor community is understand my business model and your business model needs to fit into that. I can give you many examples of many companies that have come to us and said, we have this great app, monitoring in the home, this, that, or the other thing, a mobile application, and it's $40 per person per month. As a healthcare provider, I cannot afford to add another $40 a month to the cost of providing care. And that's just from one vendor. So if I have 3 that want to do that, I have to add $120 to the cost of providing care. You may not have noticed, but the hospitals are being slammed by CMS. Mm-hmm. Reimbursement is being lowered. October 1 went into effect. The readmissions were getting dinged for unnecessary readmissions. We run on a very narrow margin. So you need to understand our business reality and have your pricing reflect what we can afford. That's my soapbox.
Very sobering and the right words, I think, for us here in the industry, absolutely. Any other last questions from our audience?
Hi, Shamit Luhar. One quick question. I've heard a lot of discussion about partnerships between businesses and I guess business to business. What I have not heard too much of, and I think Eleanor, you briefly touched on it, was the idea of forging partnerships with patients. Mm-hmm. And was interested to hear from the panel, what types of partnerships have you forged with your patients that's driving a lot of, that's resulting in a lot of the innovation?
I don't know if that was specifically addressed to me or not, but I think from a health system perspective, it really gets down to, we provide care for people when they're not feeling well, when they're sick. We're trying to move into the wellness space and support them when they're well, when they don't need to go to the hospital. So I would say it's really based on what everyone looks for, customer satisfaction. We understand we're taking care of individuals. We need to take care of them. They have families that get involved. So how are we doing with that individual? We need to understand, as I said earlier, customer preference. How do they want us to interact with them? But ultimately, it's that, underneath it all, it's a healing relationship, and we have to perform. We have to meet their expectations, and all these other, the business to business gives us tools to do that. And I think a lot of what I consider to be the enabling of more communication in a number of different ways via mHealth helps us to improve our relationship with that individual patient. So we need all this, but ultimately it's going to come back to how are we working with them individually, how are we providing them care, do they have a good outcome according to their perception and not necessarily what the health plan thinks is a good outcome. Hopefully they're the same thing. They should be the same thing, don't get me wrong, but ultimately it's that type of thing. So one last quick thing. One way that, an example of that, We literally have these 80-year-olds that we're discharging from the hospital post-operatively, and we're sending them home, as I said, with tablets where we can communicate with them, where they're automatically collecting their vital signs, et cetera, and this is to prevent readmissions, and we come back to the house and pick this up after 31 days. And the patients don't want us to come and pick them up. They want to keep them. So that's an example of how we can leverage mHealth to improve our one-to-one relationship with our patients. So we need it, we want to adopt it, but it's that, what everybody does, it's the customer experience ultimately.
Any thoughts from our payer colleagues or health plan, care management?
They don't want the tablets picked up because they don't want to give up their angry birds.
Another question from our audience here.
So just a quick question, a follow-up to your comment, Hank, about your margin. In Silicon Valley, where I live, Stanford Hospital and clinics and UCSF are investing billions, literally billions of dollars in new facilities, and that doesn't even include the the expense of installing billions more in EMR systems through Epic. And so, are they still dealing with the same margins that you are, or are they living differently?
Yeah, I think they're living a little bit differently. Number one, those are fairly large academic medical centers. The academic medical centers get buku dollars from NIH and the federal government to do a lot of research, and they can leverage that. Christus, we are literally community hospitals, 40 community hospitals, rural hospitals. So I think we are a little bit different from that perspective. It doesn't mean to discount what they're doing, but traditionally, that is the margin of the hospital industry. But the big academics, they're a little bit different, at least in my view, because part of their goal is research, part of their mission. It's research, it's education and teaching. And community hospitals were more integrated into the community at that community level. So I think they have a little bit more flexibility to do things that we would love to do, but don't have the resources to do.
Can I go back to the previous question?
Absolutely.
I had some comments I wanted to make actually about patient engagement. Scott made a comment a while ago, which I absolutely agree with. It's that 90% of what you see out there, much of which is designed for patient engagement, there's no innovation there. And I went to a conference somewhat recently, won't name it, that was focused entirely on patient engagement, and I came home thinking, if I see one more website that the patient's going to go there, they're going to use it, and because we give them a chance to win a bicycle or something, I don't know. But it was the same thing over and over. I don't think there is a lot of innovation. That's not fair. I was going to say that there's not a lot of innovation out there. I think there's a lot of noise out there from which one you have to find the innovation. I would encourage all of us I think there's too much simplistic attempts at innovation, if that's not an oxymoron. I've got this new technology, I want to engage the patient. Boom, one step. I think you need to, some of the innovation is to engage the patient less directly. If you're in health information exchange, and your customers are physicians and healthcare providers, a really, really fast way to lose your customers is to engage their patients directly and leave them out of the equation. Health information exchanges, at least ours, have we're like, who is that used to advertise, we don't make a lot of the products you buy, we make a lot of the products you buy better. I don't even know who that was. Yeah, BASF. Okay. We're kind of like the Intel Inside, the BASF. We're trying to enable our providers, our customers, to figure out how to do whatever it is they want to do. And if that includes engaging patients, then very good. But we're trying to figure out how to get more data, figure out how to distill that data into information, trying to figure out how to make that data available in new ways and in new places. And if our customers can figure out how to use that innovation to engage patients, that'd be great.
Al, could I just, I'm sorry, just
Yes,
real
of
quick, I want to
course.
go back to the question before. As far as the patient involvement, member involvement, I think we did engage them throughout this pilot. We did partner with them because we would follow up with them weekly at least, and determine what needs they're having, what issues are they, what challenges are they having using the system, what issues are they having with their care. Have they not been taking their blood sugar because they don't have any strips? Are they? When was the last time they've been to a provider? How's their diet, and so on and so forth. So we were collecting this on a weekly basis, and I think what helped us is that we were able to take this information and look at our diabetic population as a whole, as to see, where are our gaps? Where do we need to address with our diabetic population overall to help them better care for themselves? So we were able to partner with them in that sense. I think that speaks to that type of innovation. But anyway, I just wanted to add that. Thank you. Sir, sorry.
Thank you.
I'm Gabriel Dib. It's my first experience, with mobile health. My question is from the perspective of patients and health organizations. How could we evaluate the access to market, the distribution, in fact, through telecom operators, or through what we are seeing now, insurance companies, or maybe directly from solution providers? What would be the pluses, minuses, according to your experience?
So is the question around, is there a direct-to-consumer opportunity to kind of be very disruptive in that space?
From the consumer perspective, as a patient or just for wellness, to keep fit, and from the healthcare organizations, how we can evaluate these different distribution channels, directly from solution providers, and or through telecom operator, or through now insurance companies. It's what I'm trying to understand, from this exhibition. Yeah.
Thank you.
Well, I guess my quick answer is follow the money. I think there are multiple channels and multiple ways to do it. From our perspective, from the health system perspective, we don't necessarily, I don't know that the telecommunications companies have the information to help us understand what a patient may or may not have. We will uncover that ourselves and work within that particular framework. But if it's direct to consumer, the telecommunications companies can certainly do a lot there. And I know in Mexico, we have 7 hospitals in Mexico. The telecommunication company there actually started offering health insurance. And part of why they did that was because they had a billing mechanism. So by leveraging the billing mechanism that was already going out to people that may not have health insurance, they found a way to do that. And it wouldn't be because the gentleman who owns the company is the richest person in the world, but that might have something to do with it too. So I think there are multiple ways to approach it, but from a Christus, from a health system perspective, that's not something that we look to the telecommunication companies to help us with, but it's to help us once we identify who the patients are, it's to help us connect to them.
I think there's probably a cautionary note in that divisional approach to the market. If you're a telecom company and have 150,000 employees, then as a telecom entity, you're very interested in health because you want to promote the well-being of the associates that are working for you. But as soon as you get past that immediate need, the question is, who's going to take ownership for the complex clinical situation? It's easy with well patients because they tend to be generally well and they tend to have 5 or 6 areas that they could be more well. But people who are ill are seldom ill with a single diagnosis. And as much as I'd like to think that we are now or will soon be in a situation where expert advice systems and computer interactions can manage asthma, oftentimes these people come with 2 or 3 confounding diseases that create a level of complexity that exceeds the ability of a simple device or a software solution to manage. Payers, it's easy. They have lives and they want to reduce cost. But I think you really need to look at it from the standpoint not only of where's the money, but what's the goal, and who's going to take ownership for the whole person. Because the whole person is, I think, much more important than the gadget or the telephone call or the website.
I love that question that you raised, though, because, let's go back 10 years, and then we've got these disruptive pieces coming out with Minute Clinic, Take Care Clinic, where they're able to address, the basic questions of, if you've got a cold and you just need to see a nurse practitioner, how do I go in quickly? This also, also this other piece around how pharmacies are able to maybe even administer certain kinds of care, like flu shots, in a much more low-cost manner, better returns for them than, say, in a traditional care setting. Is there, therefore, a way to extend that? So I'm thinking about the American Well model, the Medi-Cal model in Mexico, kind of like a quick diagnosis. Or again, is the sense of, there are huge issues here.
Well, I'm a practicing clinician. I'm going to leave the conference and go back to Cleveland, and I'll be in the Cleveland Clinic tomorrow morning. The Minute Clinics, the American Wells, the Medi-Cals are great from the standpoint of solving an immediate need. But without John's infrastructure, they can actually create more chaos and cause more clinical harm than the fact that, Bobby got an antibiotic because his ears were sore with a viral infection, which was the complete wrong therapy for that diagnosis. But what about Bobby's primary care physician to whom he should be going on a day-to-day basis? Without the transparency and connectivity, I'm not sure that any of these one-offs are more than disruptive. They do disrupt a continuum, which is undeniably imperfect, but I think they, without correct integration and connectivity, create more harm than good.
This is, I think, a good example of one of those places where it isn't individual innovations that make the innovation, but a number of factors that have to come together. I think the American public is going to determine if the Minute Clinic kind of model is successful or not. But Scott's absolutely right that it's clinically you need to integrate the information of that care with the rest of the knowledge of that patient. And so that is, I think, an innovative model of care. Anybody that's tried to get a appointment with their primary care physician when you're sick, as opposed to a week after you feel better, knows that there's something to that business model. But we have to integrate it. We have to integrate the information. It's just an extreme case of the way the healthcare system is already fragmented. Raise your hand if you only ever see one physician.
Right.
Nobody, right? Okay. And even if you are largely, we're seeing this through analyzing the data for accountable care organizations, at least in our state, 40 to 50% of the time, a patient who is attributed by the federal government to one healthcare system, 40 to 50% of the time, that patient also receives care at another system. Okay? So by definition, even that person's home for care most of the time doesn't know about all of the information that is pertinent to that clinical care. Now we introduce Minute Clinic, an island of clinical care. We need to figure out how to, and they're trying. They are not trying to be the primary care physician. They're pretty good about saying, okay, at the end of this encounter, I have this encounter summary. Now I would like to send it to the primary care physician. How do I do that?
Yes. Yeah, because your primary care physician doesn't have the capability to absorb that information.
Well, I mean, how many here went to a Minute Clinic and got their flu shot this year, or a Minute Clinic equivalent? So did I. What happened to the data when you were done? Nothing. So I live in Cleveland. We have a couple big hospital systems. We have one of the pioneering hospitals from the standpoint of electronic health records. I have an Epic PHR that I use. How galling was it to take a piece of paper to my primary care doctor 3 weeks later, because that was the only way I could prove that I'd actually had a flu shot, so I could avoid the urging of him and his staff to get another. I know as a fact that the Minute Clinic had internet, and I know that they had an EHR because that's where all the data went when I got my $25 flu shot. And again, so without John's connectivity, you know, what's the point? And if I have a flu shot reaction 6 weeks later and show up in the emergency room partly paralyzed, people are going to scratch their head and wonder. In the 21st century, we shouldn't lack that transparency anymore.
So from an extreme innovation perspective, you know, one might say what we have is a failure of the medical profession to meet the care and convenience needs of the consumer. So if the doctors would allow their patients to communicate then via cell phone, take pictures, send it to them, use email, use voicemail, integrate everything, they could take care of those needs, but we also need to move the medical community along to adopt that model of care as well. But I agree with everything everyone said. The Minute Clinics are not trying to dominate healthcare. They're not trying to replace primary care. That information should go someplace where your care team does have access to it and knows that it happened. But I think there are also some models that could be leveraged to change the interaction with the primary care providers.
And while I agree with what you said, I also think we need to figure out how to informationally integrate
Absolutely.
those care settings because they're not going away. And if it's one thing, I can't resist. Now you're getting me fired up. If it's important to informationally integrate the flu shot that was given at the Minute Clinic into the fabric of information that our caregivers have about us, then is it not even more important when you've got someone with comorbidities whose cardiologist prescribes one medication and their neurologist prescribes another that have dangerous interactions, that fabric of information is also integrated. And it's not unusual, in fact it's quite common, that those two specialists would be either in groups that are not part of the same system, or even when they are groups that are part of the same system, that they wouldn't be able to share that information in today's healthcare system. We need to fix that.
Artie, any
Well, and I was just going to add that, you know, from our side of things, you know, if we don't see a provider giving that service or a vaccination, they'll get dinged for it, you know, on the quality measure piece. So even if it happened in a Minute Clinic, it doesn't get transferred, we can't see it. It didn't happen, according to us. So there's always that.
Well, clearly, healthcare a very challenging environment. I'm afraid we have run to the end of our time, but do feel free to come up and ask your questions to our panelists here. I just wanted to end off with a round of applause for our panelists. This was a great conversation. Thank you.